Hello everyone. Today we're going to talk about making ascites, a step-by-step guide. On future videos we'll talk about the makeup of ascites and what ascites looks like biochemically, but for this talk we're mostly going to talk about how you make ascites and why people get ascites. My name is Scott Matherly. I'm an assistant professor of medicine and I am a transplant hepatologist here at Virginia Commonwealth University. So let's talk about ascites. What does the word ascites mean? Well, it comes from the Greek for ascos, or leather bag / wine skin. Basically, it's an abnormal accumulation of fluid within the peritoneal cavity. The most common cause is liver disease, and either produced as a result of liver disease or as a result of the liver becoming congested due to outflow obstruction or congestive heart failure. Less common causes of ascites include trauma, pancreatitis, malignancy, infections, and the nephrotic syndrome. We'll talk more about those on a future talk. For now, we're going to concentrate on cirrhosis. In the normal liver, you can see that there's virtually no resistance to blood flow. Blood can flow from the portal vein through the parenchyma of the liver, out through the hepatic veins, and into the inferior vena cava with basically no resistance. And the result of this is that there's very low pressures in the portal system. And in addition, in normal people, the blood volume is carefully controlled by our functioning kidneys. Compare that with the cirrhotic liver. And in the cirrhotic liver, you have increased intrahepatic resistance to blood flow, and you have a hyperdynamic circulatory dysfunction that develops, which we'll talk about extensively in the coming slides. Before you develop ascites in the liver with cirrhosis, you start to develop increased pressure across the hepatic sinusoids, and this results from two major mechanisms. At the top there, you'll see the dominant mechanism, which is increased structural resistance. And the increased structural resistance comes from disrupted sinusoidal architecture due to the fibrosis and inflammation associated with cirrhosis, along with the architectural remodeling. And you can possibly also have outflow obstruction due to regenerative nodules, compressing veins, or thrombosis. But in addition to this, you also have an increased vascular tone. A normal liver is quite compliant, and if you increase portal flow, like say after a big meal, the liver will relax to allow the pressures within the liver to remain the same. However, in a cirrhotic liver, they lose the ability to have that sort of vascular relaxation. And this is due to decreases in endothelial relaxing factors, as well as decreased production of nitric oxide within the liver itself, and enhancement of endogenous vasoconstrictors, such as the endothelins. You can see from the formula above, changes in pressure across a system will equal flow times resistance. While in the cirrhotic liver, you have increased portal and arterial flow, you have increased resistance, and as a result, you'll develop an increased pressure that we call portal hypertension across that sinusoidal bed. So this is what the hepatic sinusoid looks like in cirrhosis. Obviously, this is a very, very simplified drawing. But basically, you have the portal vein and the hepatic artery feeding blood into the hepatic sinusoid, and that blood is eventually making its way over to the central vein. The hepatic sinusoid is flanked on either side by hepatocytes and endothelial cells. Well, in the cirrhotic liver, you have increased hydrostatic pressure, you have a decreased oncotic pressure due to low albumin, and you possibly can get outflow obstruction, as I mentioned on a previous slide. The net result of this is the Starling forces tend to push more and more fluid into the interstitial spaces, aka production of lymph, in patients with cirrhosis and portal hypertension. What is important to know is that this alone is not enough to produce significant ascites, and that you have to have some other perpetuating force in order to produce significant amounts of fluid. This would be self-limiting, obviously, if the system was not being fed. So as I mentioned, structural resistance is only half of the story. Before the liver even starts producing enough interstitial fluid to overwhelm the hepatic lymphatics, a sinister physiologic phenomenon begins to take shape outside of the liver. Before the ascites can begin, portal hypertension and cirrhosis cause a profound arterial vasodilatation to occur. The most significant vasodilatation occurs in the splanchnic arterial bed. What causes this? Well, it's multifactorial, as you might imagine, but the dominant player seems to be increased nitric oxide production. But Dr. Matherly, you just told me there's decreased nitric oxide production. Well, there does seem to be decreased nitric oxide production within the liver itself, but outside of the liver, there seems to be increased nitric oxide production. And this is secondary to several different possible reasons, including increased shear stress induced by the portal hypertension, endotoxemia from increased translocation of bacterial products, and increased VEGF production, which has been shown to be occurring in patients with portal hypertension and cirrhosis. But other things such as increased prostacyclin production and endothelial dysfunction may also be playing a role, and there's many other postulated causes. Basically, you'll get a splanchnic and systemic vasodilation due to the liver disease and inappropriate nitric oxide. This leads to arterial underfilling and reduced mean arterial pressure. Now, our bodies will recognize this and start to try to compensate. The increased sympathetic outflow that will occur will cause increased cardiac output. The heart will actually pump very strong and very fast in an effort to keep the cardiac output and ultimately the mean arterial pressure up. The kidney quickly sense this decrease in mean arterial pressure and start to activate the renin-angiotensin system, leading to the production of renin, angiotensin, and aldosterone. As a result, the kidneys will start to hold on to more salt and fluid. The brain also gets into the act and non-osmotically releases antidiuretic hormone. And basically, this increased antidiuretic hormone will cause the kidneys to hold on to even more water. The net result of this is that you'll have increased blood volume and increased pooling of that blood volume in the splanchnic circulation. The patient with cirrhosis is unable to overcome the systemic vasodilation, which actually only worsens as this goes on. The net result is you have this positive feedback loop of increasing blood volumes, increasing pooling in the splanchnic circulation, increasing vasodilatation, which just drives this process around and around. So in the hepatic sinusoid, what you'll see is that once the hepatic venous pressure gradient exceeds 10 to 12 millimeters of mercury, the liver will start producing enough lymph that it will overwhelm the hepatic lymphatics and fluid will begin to weep into the peritoneal cavity. And that is ascites. This process is fed and perpetuated by the hyperdynamic circulatory dysfunction of cirrhosis that we just described on the previous slide. So what are the hepatic lymphatics? Well, in times of health, the liver accounts for 25 to 50% of the lymph flowing through the thoracic duct. And this makes sense as that hepatic blood flow accounts for about 25% of cardiac output. In cirrhosis, however, that lymph flow can increase 30-fold, as was shown in this seminal paper from 1984. So as you can see, ascites develops when you have these two circumstances occur. You have portal hypertension with increased hydrostatic pressure in the sinusoids, and you have a decreased oncotic pressure. But in addition, driving that development of ascites is the circulatory dysfunction, where you have increased sodium and water absorption, increased blood and plasma volume, and pooling of blood in the splanchnic vasculature, which leads to increased portal blood flow. Now, the body doesn't take portal hypertension laying down. And as the portal pressure increases, portosystemic collaterals will begin to form, such as esophageal and rectal varices, splenorenal shunts, and caput medusa. Now, this can occur from three different mechanisms, as you see: dilation of pre-existing plexus of veins, remodeling or recanalization of existing veins or structures, and de novo angiogenesis. Portal clots may actually form. Now, this obviously isn't a compensatory mechanism, but this is something that certainly happens. As the portal venous blood flow slows, as the resistance in the liver increases, that blood can actually spontaneously clot. Sometimes you'll even see blood flowing in the opposite direction in the patient with cirrhosis, away from the liver, as large shunts begin to form. Then how does one produce ascites if you've clotted off your portal vein? Well, unfortunately, decreased portal blood flow will lead to a compensatory increase in hepatic arterial flow. And what you'll typically see is continued blood flow across these very hypertensive hepatic sinusoids. Ultimately, these efforts fail to decompress the splanchnic vasculature, and they only add to the problem. And what you see is a vicious cycle developing. So beginning with increased portal pressure, this causes increased vasodilatation, both in the periphery and in the splanchnic vasculature. This leads to decreased mean arterial blood pressures, This causes compensation by the heart and kidneys, which leads to increased fluid retention and ultimately will lead to the development of ascites. However, the increased fluid retention will lead to increased portal pressures, and this will lead to things such as varices, splenomegaly, shunting, portal vein thrombosis, and encephalopathy. But the increased portal pressure just causes more vasodilatation, which causes more decrease in the mean arterial pressures, increased fluid retention, and so forth and so on until the system breaks. And the end result is you end up with an unfixable and worsening systemic vasodilatation. In the kidney, this leads to dropping GFR. Initially, the kidney responds to low mean arterial pressures by constricting the efferent arteriole, allowing continued flow across the glomerulus, but eventually it starts constricting the afferent arteriole, and at that point you'll start to see decreases in GFR and development of renal failure. You'll also see a dilutional hyponatremia occur as more and more antidiuretic hormone comes from the brain, and ultimately you'll develop renal failure in the form of what we call hepatorenal syndrome. In the liver, you'll see the ascites become refractory, and we'll talk about that on future slides. You'll see the development of portal vein thrombosis in some patients, and you'll develop hepatic encephalopathy as the shunting worsens. In the heart, you'll start to develop a condition called cirrhotic cardiomyopathy, and that's when that high output cardiac function starts to decline in this setting. There are multiple other organ systems that are affected by this phenomenon, but this is the dominant three that you will see results in. So what is the natural history of ascites? Well, when most people begin with ascites, it will be easily controllable. Sometimes we can control it with something as easy as a low sodium diet. Oftentimes we'll put these folks on loop diuretics and aldosterone antagonists together. Furosemide and spironolactone are the ones that are most commonly used. And what these are going to do is basically flog the kidney to get rid of sodium and water and ultimately decrease the amount of blood volume that is building up and the amount of ascites that is produced, allowing the lymphatics to control the problem. However, eventually, as that systemic circulatory dysfunction begins to progress, the patients will ultimately become intolerant to diuretics, and this is a condition we call refractory ascites. In this one, we often have systemic hypotension. It's very common for our patients to be running systolic blood pressures in the 90s. You will often see hyponatremia with blood sodium levels dipping down into the 120s or sometimes even worse. And these folks will often require recurrent paracentesis. Now, oftentimes at this point, we can consider an option for treatment such as a TIPS, a TIPS. It's the transjugular intrahepatic portosystemic shunt. And what this does is it decompresses the portal system and basically decreases the portal pressure significantly. Now, TIPS can reverse this whole phenomenon and get control of refractory ascites. It can get rid of varices and variceal bleeding, and it can also improve hyponatremia and renal blood flow. The other thing that could really help in this situation is a liver transplant. And oftentimes, once patients develop ascites, we start to evaluate them for whether a liver transplant would be a good option for them. If this whole system is allowed to continue, the circulatory dysfunction is allowed to continue to worsen, what will eventually happen is the patient will develop hepatorenal syndrome. And what hepatorenal syndrome is a progressive worsening and decline of renal function, which can either be fast as type 1 or slow with type 2. And ultimately, this will lead to death without liver transplant. So in conclusion, ascites development in cirrhosis results from a combination of two pathologic factors. One is portal hypertension at the level of the hepatic sinusoid. The other is circulatory dysfunction leading to sodium and water retention. Although essentially hepatic lymph, ascites is a sign of a much larger underlying dysfunction involving multiple organ systems. On the next lecture, we will talk about what makes up ascites and how to tell them all apart. Thank you very much, and I hope you enjoyed this short lecture.